specific receptor, in this case the TROP2 receptor on the surface, which is widely expressed on cervical and endometrial cancer cells, and it has a topoisomerase inhibitor basically attached to it. So I always tell my patients I could cure their cancer if I wouldn't kill them with the amount of chemo I would need to do. Essentially, it's like smart bombing the tumor, so giving really, really high doses of chemotherapy to the tumor itself and then limiting that toxicity to normal tissues that don't express the TROP2. There was, in the phase 1-2 study of that, there was a dose of 4 milligrams per kilogram, and essentially there was a response rate of 31 to 34% in both the 4 milligram and 5 milligram arms, and side effect profile was a lot of things like hematologic toxicity, some mucositis, things like that. Unfortunately, she got the Taxol arm, so she did not get put on that study, but we do have the sister study to that open in our institution in cervical cancer, and we're looking forward to seeing the results of 3095. So the A-Link trial, which was what was really cool for her, Dr. Tang joined us a couple years ago and set up a phase 1 clinical trials unit, and has really plugged and played really nicely with our GYN cancer group. I think our patients, we proudly put about 20 to 30% of our GYN cancer patients on clinical trials, and so they're very warmed up to the idea by the time they get to phase 1 territory. And so again, for most of you know, but phase 1 means that these are like first in human studies, so you have to be kind of warmed up to that concept to go there. But we've had a number of very highly motivated patients, and we've had some excellent colleagues like Dr. Hamilton and Valente and the such that have kindly shared their patients with us, and just because these trials have been great. So ALK 201 is a novel high affinity FR2 beta targeting antibody. And it's an antibody drug conjugate, and it's stuck to a topoisomerase inhibitor. And so this patient went on that trial, and you can see when she had been on 3095 with me, she had stable disease for a while, and then she just developed this left parasternal mass that was, you could see it across the room. It just was like 6 centimeters. It was huge. And then you can see on the right what she did, and it got down to about 3 centimeters. Same trial, different patient. This is a 25-year-old woman with a rare cancer, which is another really great place to have these phase 1 trials, because as we all know, it's not rare to take care of rare cancers, but there are a lot of them. And so I can't have a clinical trial open for every rare cancer that exists, because that's just prohibitive. So this lady had a laparoscopic cystectomy and was diagnosed with a juvenile granulosa cell tumor. These are extremely rare tumors, about 0.4 to 1.7 per 100,000 women. Granulosa cell tumors themselves are rare tumors. These are less than 5% of granulosa cell tumors. So they're very rare. I think I've taken care of 2 in my entire career, okay? She was pregnant. She got the treatment that these patients usually get, which is there's no real standard of care because no one knows what to do. There have never been more than like series of 5 or 6 or 10 at a time. So nobody has a lot of experience, and so we do what we usually do for ovary and GYN cancers. We throw carbo and Taxol at them, which is totally appropriate. It's what I would do. And she kept recurring, essentially. And she's like a young mom. She's like having babies through all of this, which is wild. Anyway, she came and saw me with a pelvic mass and wanted to know what I thought she should do. And I was like, I have no idea. No one knows what you should do. And fortunately, Dr. Tang had this A-Link trial open, and we did have a path review, and they suggested that it might not be a juvenile granulosa cell tumor. It might be a steroid cell tumor, NOS. It really doesn't matter. That's also an extremely rare tumor. And so we don't have a standard for that either. But both are stromal cell tumors of the ovary. And she got put on the A-Link trial and has had a really impressive partial response. So this 6 centimeter tumor is now like 2.8 by 1.2 centimeters in her pelvis, and she's doing great with minimal toxicity. And again, this is a young woman with a kid, so it's potentially, hopefully, durable therapy, which is just really great. CS is a patient of mine who had a recurrent KRAS wild-type low-grade serous ovarian cancer, and we put her on Veristem's trial RAMP 301. So she, in July of 2015, had a HIS-BSO and debulking for a low-grade serous ovarian cancer, was treated with carbo and Taxol at that time, and then recurred. She went back to the OR for a cholecystectomy with GenSurge. They took out her gallbladder and then debulked some of her disease, but she still had a lot left in her abdomen and pelvis, and that's when she came and met me, was after that. And we treated her with carbo, Taxol, and bevacizumab maintenance. She stopped in May of 2024 with the bevacizumab maintenance, and then in January of 2025 developed progressive disease, enrolled in RAMP and was randomized to avutametinib and defactinib, which I'll talk to you guys about, and had a nice partial response to that as well. So if you don't know much about low-grade serous ovarian cancer, it's actually quite a distinct entity from high-grade serous ovarian cancer. The pathophysiology is different, the behavior of the tumor is different. Cytoreduction is everything, and it doesn't move very fast, but it also doesn't respond really well to a lot of things we throw at it. And so avutametinib and defactinib together work in a really interesting way. Avutametinib is a first-in-class oral RAF and MET clamp, and it inhibits MET kinase activity while also blocking compensatory reactivation of MET by upstream RAF. And then there's this pathway sort of to the far right that you see through FAK that basically is like a roundabout way that the tumors kind of compensate when you typically block the RAF MET clamp. And so you add the FAK inhibition to that and you get more impressive activity. So the bottom waterfall plot is showing you data from the RAMP 201 study, which was the phase 2 study looking at avutametinib versus avutametinib plus defactinib, and basically selected the combination as the way to go forward. It was really impressive, and there was a more impressive response rate with KRAS wild type and with KRAS or with KRAS mutant than wild type, but you can see there's activity across the board. So this clinical trial is what we opened, and we were very excited about it. And put a number of patients on it. And even though I can't have a trial for every rare tumor, I would say I really enjoyed having this trial open because I felt like even though low-grade serous are rare, the patients really came out of the woodwork for this one, which was great. And they got randomized to avutametinib and defactinib versus investigator's choice chemotherapy. And the ones that got investigator's choice chemotherapy had the option later to, if they progressed, to cross over to the investigational arm, which was a nice option on this trial. They recently narrowed it down to wild type only, and now they've even more than that, actually limited it to only KRAS wild types, and they only want patients with elevated liver functions, which is really interesting. I can't find those patients, but it's almost closed, I think. And then basically she's had an ongoing durable partial response, and so we're very excited about that. And it's just nice to see patients respond well. So with regards to rare tumors, I think this is really where clinical trials pack a punch. We're really just pulling out of a grab bag most of the time for these patients. It's very hard to study these tumors. It's very hard to fund, run, and complete these trials, especially for the very slow-growing tumors like granulosa cell tumors and low-grade serous. And then the business incentives are really lacking. I mean, who wants to have a blowout drug for something that only 0.4 in 100,000 women get? Not many people. But having a rare cancer is not a rare event, and commitment to studying these requires vision and commitment on behalf of the institutions as well as industry, and then the NCI and other things. So targeted and precision medicine strategies and advances in AI, I think, are going to be the two of the biggest things that will help us tackle this. I think a lot of these rare tumors are, once you can throw them through some next generation sequencing, you'll have targets and things you can tackle them with, and you can group them with stuff. And then AI, of course, is helping us data mine all this information. And this is an 80-year-old woman, and another one I shared with Dr. Valente, who had a laparotomy for diverticulitis and was found to have ovarian cancer. Colorectal surgery, gyn-onc did a big combo case, cytoreduced her, and she got carbo and Taxol and then olaparib maintenance, and then in June of 2024 she progressed and was treated with carbo, gem, bev, and bev maintenance, and then had progressive disease and was now platinum resistant, was treated with mirvetuximab, which is our first antibody drug conjugate in the ovarian cancer space that targets the folate receptor, which was very exciting. And then in October, she progressed and we treated her on the Rainfall trial. She was treated with Rina-S. Her CA-125 went from 82,000 down to a nadir of 2,000. Her target lesions did also respond, and she had a 64% reduction from baseline. She ultimately had a partial response. So these are her imaging showing that partial response. And then this is Rainfall 1, which was basically the trial that informed the Rainfall 2 trial that we had open. And what it is it's a phase 1 study of these medications. And you can see that you can see the impressive response rate. So, and what those little pink versus blue bars is whether or not patients were folate receptor alpha positive or negative. And there's activity even in the folate receptor negative group. And I think that's what's really interesting here. And it can follow mirvetuximab. So I think, even though both mirvetuximab and Rina-S are targeting the folate receptor alpha, they're linked to very different chemotherapies. So mirvetuximab is linked to DM4, which works on tubulin inhibition, and then exatecan is a topoisomerase 1 inhibitor. So they're different chemotherapies, same target, and they can chase each other. So it doesn't necessarily mean that if you use one, you can't use the other, or vice versa. But in this phase 1 study, it showed really impressive activity. And so based on that, we went ahead and tackled that. Now, there was an endometrial cancer cohort we're really excited about, and at a median of 1 year, there was a deep and durable response to Rina-S as well, with an overall response rate of 50% and a disease control rate of 100%. And so we're excited because we're about to open up there's like 6 rainfalls. I think it's rainfall 3 or 4. One of them is for endometrial cancer, so that's about to come. So what's next? So these are our little clinical trials maps that my partners and I use when we're organizing what we're doing. And I've talked to you about a number of these trials already, but just some commentary on the importance of cooperative groups and the teamwork that goes into that. GOG 3088 is leiomyosarcoma study, rare tumor. So we need the foresight of these organizations. NRGGY032 is actually a de-escalation study. And I think this is one of the things that concerns me the most about national funding through the NCI and things like that being potentially cut is our industry partners are going to come up with cool new toys, which is awesome. But we need somebody to help us figure out how to rein that in. And that's really where national funding, I think, comes in, and these NRG cooperative groups come in. You've got NRGGY035, which we've just opened, which we're very excited about, and that's for P53 mutant advanced or recurrent endometrial cancers, and it's carbotaxol Bev, carbotaxol Pembro, or carbotaxol Pembro Bev, and that's Dr. Fader's study. And then Rainfall 3, which is going to be the Rina-S in the endometrial cancer space, and we do still have. It's called Durafac, which is basically the same thing as RAMP, or the same combination as RAMP, but for KRAS mutated any other cancer other than at low-grade serous ovary. So we've been enrolling to that well. In the cervical cancer space, there's NRGGY037, which we're very excited about. Essentially, 2 big studies hit about the same time. There was the Interlace trial showing neoadjuvant chemotherapy would help improve progression-free and overall survival in patients who are getting cis-RT and brachytherapy for locally advanced cervical cancer. And then we had the Keynote A18 study, which showed that adding pembrolizumab to cis-RT and chemoradiation and brachytherapy for locally advanced cervical cancer improved survival as well. And so now the question is, should we do one or the other? Is there a way to combine them? This study's kind of clever. It's basically the Keynote A18 regimen versus that with some lead-in neoadjuvant chemotherapy. So that'll be a fun one to have open as well. Again, Durafac's open in that space as well, and the GOG 3095 sister study, GOG 33101, with the antibody drug conjugate against TROP2 is open in that space as well. In epithelial ovarian cancer, we have a number of frontline studies. HOT is a HIPEC study. 3115 is looking at combining mirvetuximab, which is the antibody drug conjugate against folate receptor, with carboplatin. GY036 is another de-escalation kind of study. It's olaparib for 1 versus 2 years. And plus minus investigator choice of Bev, so potentially helping us answer 2 questions, although really just 1, but hopefully 2. And then Rainfall 4 is replacing Gloriosa. Gloriosa was a very popular trial. We actually, I think, both had it open at both Ochsner and at LSU. But essentially, it was adding mirvetuximab and Bev versus Bev alone maintenance in folate receptor alpha positive recurrent platinum-sensitive ovarian cancer, which I know is a mouthful, but a Rainfall of 4 is going to replace that, and that's going to be using the Rina-S agent instead. So that'll be really interesting. And then we, of course, have we had Rainfall open for the platinum-resistant ovarian cancer, and that enrolled faster than I think I've ever seen anything enroll in my entire life. And we're getting Catalina, which is going to be a CDLN6 antibody-drug conjugate study in the platinum-resistant ovarian cancer space. So we're excited. I wish I could explain to you, my entire fellowship was I feel like every study was, do we give carbo and Taxol weekly or every 3 weeks? And do we give radiation first or after? And it was just very repetitive. And now we actually have a lot of stuff to play with, which is really great. And then there's enhancing access for Louisiana and the Gulf South. And I think the first and foremost thing I think I would have to say is that we're very lucky in this, our GYN oncology ecosystem here is a very friendly, collaborative one. And I think that's the best possible thing for our patients. So I really appreciate this community. I think it works in the best interest of our patients. Sometimes our patients really have a lot of odds against them. Something I'm very proud of is our Rare Camellias program. And so essentially, we had a number of patients with cancer who were being seen in Lafayette. And Ochsner has recently jumped in to fill a very needed burden there because there's just nobody physically there all the time. But for the last several years, there was no one, and we have an LSU GYN who is out there who was sending us a lot of patients. So we came up with the Steel Magnolias program, which essentially allows for virtual hybrid visits. It was spawned by COVID, and then we realized that we had a number of patients who were candidates for clinical trials, especially really simple surgical clinical trials. So we had this one, NRG-CC010, which is a sentinel versus full pelvic node dissection study done through the NCI. And essentially, they would come to us for surgery, and they can do all their follow-up at UHC in Lafayette. And one of the things that's very cool, there's a poster about it here, and we're going to be presenting it as well at SGO, is that we have very, very low deviation rates, actually lower deviation rates in our Rare Camellias group than in our patients that standardly follow us. And I think that's probably because we have this mechanism in place and it's not such a burden for them to see the gynecologist close to home in Lafayette, but we have other patients that come from afar, and we don't have that mechanism in place. And it is a lot to ask somebody to come back every 3 months so I can measure their legs or whatever it is. So we're very proud of that. We were the leading enrolling site for the sister study nationally, and so that's something we're very proud of. That was a social intervention study for African American women with endometrial cancer, and it was looking at 3 different ways of supporting women through that diagnosis. It was a very, very pragmatic study with the outcome of being, did they get through the cancer treatment that was prescribed? And so we were very, very excited about that study. And then we have our LSU GYN Oncology Fund, which we use to support patients. So I have a patient right now today who's getting chemotherapy, who's using these funds. And essentially, we have a number of patients that can only get care with my group where we practice just based on their insurance situation. And it's really hard to have to travel 4 or 5 hours every time you need treatment. And so we can set them up in a hotel, or we can help them with costs, especially if they're doing something brave like enrolling on a clinical trial. We want to support them as much as we can so it's not a big financial burden because they're usually strapped. As we all know, cancer is expensive. And we usually have a TLT to fundraise for this. So save the date, September 16th. So I'd like to thank my team. So I work with 2 fabulous GYN oncologists. I have some wonderful nurses like Beth sitting in the audience and Krishana, and then 2 fabulous APPs that work with us. Our brave patients, of course, because none of this is possible without them taking a risk and going on these trials, and we learned so much from them. CAGLA, because I do think I've rarely been part of an organization that was so good at crossing the different institutions. It's very collaborative. The Al Copeland Foundation has been extremely supportive of our work, my LSU colleagues and faculty, LCMC for their vision, and then the New Orleans and Louisiana GYN cancer community, as well as my family because they put up with me. And that's it. These are my references. Questions? Okay. Well, I was going to do a little panel, but we can break early if you guys want. If you want to be bad. I think we're good. All right. Go get some coffee or something. All right.
Hey,
I have to tell you, they just call me the all PA soundman out in the war department.
Everybody try to unplug it.
Yeah, I did. Yeah. Yeah. Sorry. Yeah. It's nice to finally meet you. I've been meaning to kind of talk to you a bit about overall and everything, and so I was kind of wondering like what your practice is with that. A little bit, yeah. I know some institutions
Like Somebody new about Carmel. I've never been to Carmel like that. That place is unbelievable. From the traffic circles, I go, yeah, you better know how to get around this because otherwise you're going to freaking blast it. Yeah, exactly. You don't know how to get over there.
It's like being in Europe.
It is. Yeah, down the wrong side of the road, right? Yes. And luckily, it's the right country. Yeah. European countries.
We don't do
By the way, you're going to Italy. So we're going to go. We're going to go early in Turkey. So, but we wanted to know, like, where are you going? Are you going to Amalfi Coast?
So we're not going to Amalfi Coast. We're doing. I can't remember the name every time. The guy just said it on Twitter. It's not Amalfi. It's something else.
You flying into Rome?
We're flying to Rome.
That's an island.
What is this? He's like,
No offense. That's it. She's been watching it. It's like higher in the day. It's like pretty wonderful. Really nice. Slacks, t-shirt, long sleeves, like
Gonna work on it, and there was
kind of the same way.
Kind of the same thing with
It's up to you. I got a point.
I gotta check it. I don't know what that line is. Right, yeah, so that's it could be, what I hate is multiple lines where you just wait for a hour and then get another one.
Because United has like
They do, they've got a quick throw. If I've done it before. Right, I know, yeah, exactly. They say it's your quick drop, and I'm like, that's not quick. Right, exactly. Right, exactly. No, your job is to get your bags on the conveyor belts and get out of there. It's funny.
Microphone check, 1, 2, 1, 2.
Collaborate on some things, and a bunch of stuff I made, and
Yeah, they had to read to my dad and like off the translation. And the presentation also. This is home, yeah, basically it's my water.
you're heading to STO.
Thank you. Just, yeah, you know. He's not even wrong.
So my wife, like my mother, stalked her every day at a dinner program, and she's rocking the day.
That was when he was still affordable. Now he's like, we have like, well, first off, I'm actually speaking this time.
I can see you up there.
Chad would love to babysit.
My wife would. Like, this is the only baby I've seen that cutest. Actually hold and enjoy.
Three, five,
Trying to get a girl.
I think 4.
We had 2 girls, and then my wife's like, what do you think? It's like, we get 20 girls.
Yeah.
Yeah.
My husband says that about if we have another boy. He's like, I don't know if it's to my mom. I can't do this. We don't have a family here. We don't work. Like, oh, say how ready. We're not able to do this. But I wasn't in LA yesterday, and one of the receptionists called me. We're like, Valente, you look like you want one more. I'm like, no. Well, you're on the wrong impression.
Did you get a surgery yesterday?
Laser, that laser.
Okay.
Good little lasers. A whole complex.
I couldn't tell. Could you tell? She was so eutrophic. There was like white, atrophy, white navy display.
Yeah.
So she was on estrogen, I hope.
She was. So I had put a whole lot of doubts, so I was in the long and looked, and there was just one area in the right venus, not right. So we lasered that, and she said they were so branches.
I love the Sonos-Pet estrogen.
You did?
By the way, yeah. It was so much easier.
Lasers.
Hopefully see you guys.
All right.
you well.
I'm coming for lunch next week to fill in for one of our reps.
Oh, good.
So,
On Wednesday,
yeah.
I tell you, she did everything
Don't look at this.
And then they opened up the site, not for, that was P-Rock, the patient had their,
Oh, I didn't know that.
Yeah, she went to Charleston to see her parents.
Let me look at USB-C. I think we have to go to connect. But just need to get power down, but battery.
I think we're done in here. What y'all doing?
Streaming from that
Or-
speaker over here.
Okay, for overflow or something. Yeah, we're good in this room, I believe. I think 4 is
Did
done.
we get the feedback taken care of on the microphone?
Y'all,
Yeah.
no, this room's done.
During,
I
for the
thi-
whole day it's done?
For in this room, yeah, there's just no track 4 p.m. today. We just didn't have enough to fill it. So y'all can do whatever y'all need to.
I'm just gonna play the video from everything, you don't have to worry about that. No, we don't even need that.
You can change it over for tomorrow? Tomorrow?
If no one else is coming here, then problem solved.
Yeah, ain't nobody coming. What's going on,
It's just
Chase?
the last presentation. All good, man.
Oh, I forgot.
If you need anything,
Yes, sir. Thank you, Terrence.
Let's find out the window of the presentation. So we can leave this going for a while. I don't know what. Should have click 4, right?
Yeah.
never been to a conference like this before.
I love that it is a multidisciplinary conference.
CADMA is bringing together people who have different roles, but all
You know what? Can I use this to power the laptop?
Yeah, absolutely. And actually, we swapped this where.
Do you think Jacob would?
Yeah, I mean,
A
yeah.
little like,
Yeah.
track 4. Okay, and it's not going to get a second meeting. Second meeting on this. You know what?
Come for the speaker again.
Whoever gets in that room, it's Yeah, here.